And no disclosures, and once again, everything is off-label. So the first case is a 3-year-old girl with a history of ocular albinism, neurodevelopmentally intact, and had several months of progressive but mild unsteadiness and hand tremors, starting in the spring of 2015. And then in October of 2015, she started losing motor and speech milestones with new difficulty climbing into a chair and some slurring and slowed speech. By mid-November, she had strabismus leading to an MRI. She had no headache. And here's her scan. So she has this, you can see, large structure indenting her brainstem. Here's the T2. And here's the sagittal post-GAD. You can see it's an enhancing mass. And on the MRA, you can see that it has arterial signal in a large, what looks like a large venous structure anterior to the brainstem, very suggestive of direct flow. Whoops, sorry about that. Very suggestive of direct flow. Sorry, I keep doing that. From the basilar to this pouch, and that was confirmed on angiography. So you can see on the right vertebral artery injection on the left side of the screen, there's direct flow from the close to the top of the basilar artery into this enormous pouch, which fills out, and that corresponds to that structure seen on MR. And here's the rotational angio, which shows the same thing, really just a direct jet of blood from the basilar into this vein. And that's confirmed here with microcatheter, so you can see, for some reason I can't, I don't know if there's a pointer, no. But you can see that the microwire just floats right into this cavity. There's no discrete feeder to point to, it's just the basilar artery pouring into this vein. So I guess one more slide before I ask some audience suggestions. You can get past the top of this supply to the top of the basilar, and you can see the left PCA filling there. So I guess, do people have ideas in terms of what this is or treatment? Or?
Yeah, I had an identical case. It's a kid's patient was from Alaska and still sends me a salmon every year. So that's now about 20 years. So what we did, we just put an enormous amount of coils in the venous pouch, and eventually it just actually worked. I was surprised. So it's a very typical location, and at least in my single experience, it worked very well with simply coiling the entire pouch.
Yeah, so as with the intraspinal component here, because of the mass effect and the worsening symptoms of mass effect, I was concerned about that. And in fact, she continued to deteriorate. So you can see a few days later, there was worsening ataxia. She now had swallowing difficulty, so that after that diagnostic angiogram I did, we had to admit her. We moved her to the ICU. She could then no longer stand, and her speech became garbled. So the mass effect was reaching a critical point. There is very sparse literature on this, so if you look at brainstem AVF and compression, there's almost nothing to find. There are some papers on posterior fossa vascular lesions that can secondarily cause brainstem mass effect, but in terms of a direct basilar supply to a malformation causing this, the only thing I did find is actually within this collection of cases from Pierre's group back in 2004 is this particular case you see at the bottom, which looks very similar. It's a large venous pouch compressing the brainstem coming off close to the top of the basilar, but the difference is that they actually had a feeder, and I'm sorry I can't point to it here with the mouse, but if you look at that top left image, there is a discrete channel going up before it empties into the big venous pouch, and because of that, they were able to deploy a little coil. Oh, perfect. So right here, and they were able to just deploy a little coil and essentially turn off that flow, and they had a fantastic outcome. But I didn't have anything analogous to that. There's just a direct jet. There's nothing to place a coil into. So I felt that my hand was forced here because of the progressive decline of the patient, and I decided to occlude the disease segment, similar to what Ferg was just talking about. And in this case, I actually did decide to use an MVP device. And the MVP device, for those of you who don't know, is a cup, a nitinol cup that has a PTFA coating on the bottom. The top of it is an open cup, and that was appealing to me because I knew that would be sitting close to the top of the basilar, and I thought hopefully that would keep the top of the basilar open. It's available in two sizes, a 3 and a 5 millimeter, and you get instant occlusion. That's another attraction of this device. It was developed for use in the peripheral vasculature, but it's used in cervical verts and ICAs. So we pre-treated the patient with aspirin, and then I had access from both groins, and then we deployed the device, and you can just see the top of the device is this marker up here, and the microcatheter, and here you can see the top of the device sitting here after withdrawal. And here's the immediate post-procedure angiogram. You can see there's still some filling of something from below via ICAs and some pontine perforators, and we'll see this afterwards. I'll come back to this, but certainly flow into that big varix has stopped. And here you can see there's stasis in the varix on the unsubtracted images. So here's the pre and the post. And you can see the filling from above is filling down the top of the basilar into the superior cerebellar arteries with something going on up here as well. Okay, so we looked for filling defects that were growing for a while. Nothing was there. We sent the patient heparinized to the ICU. I was terrified of any thrombosis growing above or below, and we kept the patient heparinized. I gave some Decadron because I was also worried about brainstem edema, and we got an MRI that same day, and here's the MR, the MRA, and here's the T2-weighted MRI, so pretty instant thrombosis of the varix, a little bit of relief of the mass effect right away, so that's later that night. And then here's the, there was no edema to speak of, so I didn't keep the patient on corticosteroids. And then here's the DWI. There was really just a little ditzel here in the bottom of the pons. And the patient woke up fantastically well, was extubated that evening. The speech was immediately improved. We kept her in the ICU. We kept her as an inpatient for about a week, and then was discharged, still discharged on heparin. And I repeated an MRI 2 weeks later prior to stopping low molecular weight heparin, and you can see this is about the 2-week angiogram, significant relief of the mass effect. And here's the angiogram, and I have to say it has stayed with this appearance since then, so this is almost 2 years now. And the question that I have really is, what does this represent? So we'll come back to this image. You can see something is going on along the tentorium, something within the parenchyma of the cerebellum, and I'll show you some cross-sectional imaging. And the question is, what is that? So she's completely neurologically intact. I'll just show you a little video. So she can fight with her brother, no problem. And here's her most recent scan, actually, just this past August, really no mass effect to speak of. But clearly with these abnormal flow voids in the cerebellar peduncle and along the tentorium. And my questions are, first of all, what is this? Is this an actual multifocal AVF? And if so, why did that one site in front of the brainstem grow explosively and everything else just sort of stayed small? Or is this a massive single-hole fistula that induced secondary smaller shunts of the type that Karel was talking about earlier today? And if so, why have they not regressed since that's been shut? The patient actually was found to have a duplication in the endoglin gene. She has no clinical manifestations of HHT. And the question is, should I treat these other things? I'm not eager to go into those pontine perforators, even into the ICA branches in a child who looks perfectly well. And I'd love to get some feedback. Yep.
Yeah, so we had a vein of Galen 19-year follow-up after the original embolization, and it showed a similar type of pattern. And then I thought back to a case that we had with Pierre, where we had the cerebellar AVM draining into the vein of Galen, and we embolized and was surgically removed the posterior false AVM, and the vein of Galen showed exactly also this kind of pattern, and with slight shunting. And so in my opinion, it is actually the clotted part of the vein that is now showing with vasovasorum or whatever. It's a live type of thing. I think it is within the vein, the wall of the vein. The
previous vein was more on the right side of the basilar, no?
On both sides.
Well, the mass effect, I think the dome grew to the right, but I think the vein actually drained to the left. I think its pattern was actually down to the left. Would anyone treat this, I guess, is the practical question.
So
This is the current, this is the current MRI.
So it looks like
Yeah. See, it's not vessels. It's. I mean, there is enhancement, right? There is tissue there that seems to be enhancing. That made me think that it could be the clotted portion of the venous pouch.
That's it. I mean, it sounds like she's doing well clinically,
Yep.
and I definitely, based on the concern that this may be, it's reasonable to watch. I agree. I think that would be very dangerous too. The only access you have to go there, that if this was a fistula, it had to be tried to venous approachable, I think. But I think this is mostly wall, it might be another 2%. So likely to watch.
Yep. Right.
My question is, if this grows and you have to consider retreatment, there may be, some benefit to trying a basket to see if it has some effect, since you have evidence that this kidney has some genetic features of the condition.
Yeah, although I wonder where this fits into the classification system that Timo talked about today. Is this actually lower risk? If it is an actual arteriovenous shunt, is it actually lower risk than a non-HHT? I don't know. Yeah, I'm certainly reluctant to treat. All right, I'll go to the next case. Yep, sorry.
One question, you used an occluder.
Yep.
Why did you choose for that, and why not for recording of the second?
So I was mostly worried about being able to deploy it exactly where I needed to. So I wanted to be over the ostium, which I could see in the lateral plane, and keep the top of the basilar open. And I was afraid that any coil or something like the pod device or something like that, I wouldn't be able to just put it exactly where I needed to.
Did you do any kind of balloon testing to see if that second actually?
I didn't, no, not in this case. She was declining pretty fast. I didn't really think I had a lot of.
Speaking, the only thing I would have considered would be to deploy that. I know that if you had a microcatheter in the venous pouch, just in case it didn't occlude completely, to have a safeguard in terms of place a few coils to slow down. That would be the only thought I would have.
Right.
But you have the risk when you're pulling
Right.
out that could
Right.
move.
Right. All right, case 2. This is an 11-year-old boy who had a clear onset of headache 1 week prior to transfer from another hospital that was progressive and unrelenting. He's neurologically intact. Interestingly, a year prior, in March of 2016, he had this unclear clinical episode that consisted of hepatomegaly, loss of 2 adult teeth with increase in his inflammatory markers, and his connective tissue disorder workup was negative. But the loss of the teeth led to some cranial imaging, and that was unremarked upon at the time. And also of note, the patient's uncle died of a ruptured brain aneurysm, as did that uncle's own father. So here's his scan back from 2016, and what you'll notice is there's a little bit of subtle soft tissue in front of the pons over here, and you can see it a little bit on the sagittal view. I wasn't so surprised that wasn't commented on, but the patient actually had an MRI, and this was not called either. So you can see enlargement of the basilar artery over here, at that time 9 millimeters in 2016. So when we got a scan when he came to us, this is what he had. So this is now a very large lower mid-basilar fusiform aneurysm with some blebs, not so dissimilar from Adam's case, although lower down. And here's the MR. And here is the angiogram. So fairly slow filling and delayed emptying, as you might expect for an aneurysm this size. Here's rotational angiograms. And if you notice, there is quite a bit of narrowing here at the rostral end of this. So we were hypothesizing, is this a dissection, or is it just the artery's a little kinked because of the size of the aneurysm? And then I did sort of a poor man's balloon test occlusion on this occasion, where I just occluded one vert to see if I could see any appreciable flow back down the top of the basilar, because the antegrade flow was so slow, and I really couldn't appreciate anything like that. So I guess why don't I stop here and ask people what they would be thinking. I solicited advice, and of course, in all cases like this, got contradictory advice. I'm curious what people are thinking now. Would anyone think of a flow diverter here?
So this case is just like the one when I was in Cleveland, the famous case that made all the money for Medtronic and that.
You mean this one?
Yeah,
Yeah.
that case. This case, what was interesting about this is Australians published afterwards a lot of complications of fusiform basilar aneurysms. This case doesn't have that stenosis that yours does. And looking at the two, I thought they looked quite similar except for that stenosis. And I think that's the problem with flow diversion in this, plus the fact that it's highly risky in the posterior circulation and that this case was lucky.
Yeah, and I spoke to Kim Nelson about this case, and he thought that in honesty, they sort of lucked out with how well it worked out. But this was actually the third pipeline case ever published. It was a 13-year-old girl, and I'll just mention that, and this had a fantastic outcome, beautiful remodeling, basically no morbidity. But I will point out that it's not a random fact that even early on in the development of pipeline, there were children being treated because these kinds of aneurysms are overrepresented in children. So that's been shown in many studies. And if you just look at the fusiform and giant column here, they're much overrepresented compared to any adult cohort. We actually looked at this systematically within the pediatric age group, and the younger you get, the likelier they are to be fusiform and dissecting. So it's not a total surprise that this is happening in a child. But as was pointed out, the morbidity in this location is extremely high. So this is Adnan Siddiqui's publication, and you can just see a very high rate of poor outcomes, deaths, and poor neurologic outcomes. And this is from the Cleveland Clinic, and you can see the Röntgen 6 cases were basilar fusiform aneurysms. So we thought seriously about a flow diverter here, but ended up opting against it. So here I did a balloon test occluding both verts at the same time and injecting the ICA. And now when you do that, you actually can see contrast slowly come all the way back down through the aneurysm and even below. You can see it get back down to the V4 if you wait long enough. So I knew that was potentially possible. And that's in fact what I decided to do. So I occluded both verts, and I wanted to promote flow reversal. So I occluded the right vert distal to its pica, but the left vert proximal to its pica. So here's the right vert injection post-coiling, and here's the left vert injection post-coiling, and here's the ICA injection post-coiling. And you can see, if you wait long enough, the contrast coming all the way back down to that left V4. And the patient did fantastically well, woke up, no DWI, woke up fine. And there was pretty rapid development of early thrombus in the aneurysm. What's been actually very interesting is, so I treated this patient back in July, and there was thrombus, and then I discharged him again on aspirin on therapeutic dose of low molecular weight heparin. And interestingly, when we got the first follow-up scan, looked sort of like his initial post-treatment. Then the next one, there was actually more enhancement, and I got the sense that the thrombosing segment was unthrombosing, and I got a little nervous about that. So we switched him from therapeutic dose heparin to prophylactic dose heparin, and he then developed severe headaches, and we brought him back for more scan, and you can see it's thrombosing more, which I'm happy about, but also nervous about. So I'm not quite sure how long he's still on low molecular weight heparin, and it's sort of walking a tightrope between the rate of thrombosis here. I don't think I'll actually exhale until I see a shrinkage in the size of the aneurysm, which is about the same size. Any comments?
It's a little bit worrisome about the last images that there's still persistent enhancement.
Yeah.
Like, this is the one part that, from our experience, tells us that the aneurysm is unlikely to shrink because something is still happening in the wall, be it vasovasorum or anything else. But this would be, for me, the most worrisome feature. Is the patient still on steroids?
He's not on steroids, no. I put him on steroids for the headache, actually, and that improved the headache, but not anymore.
These are the cases we have to go to surgery and decompress the wall, so reconstruct the vessel. So don't discard that you may need to go to open surgery to take some of the mass out. And we have a few cases that we had to control in the vascular, and we lumen seems to be reconstructed, but the aneurysm keeps enhancing like this. So we then go to surgery, you cut this aneurysm wall, you leave a little bit of the wall, but then all of a sudden you just remove the content of it, you find maybe where it's coming from, reconstruct that, and that may be the only way to deal with it. Especially if it grows in size.
Yeah.
Like that.
The group from Helsinki, last week presented on cases that had wall enhancement like you show here. And they put the patients on steroids. And what they saw was actually that enhancement degraded and the aneurysm was not growing as much. So that might be an idea.
But exactly. So do a few days, but what we did mistake, right, is that if you keep for too long with steroids, then at one point they're not going to reverse their neurological deficit anymore. If it fails, it fails. And so you need to make a decision to have a plan that you do a week, 10 days. If they continue to progress, at one point you need to make a call.
Just stop?
Yes.
Okay. Thank you.